Welcome to eHealth Radio. I'm Linda DeWitt. Our topic today is Colon Cancer Awareness Month. The American Cancer Society estimates almost 97,000 new cases of colon cancer in the U.S. this year. The good news? There's been a 30% drop in cancer rates over the past decade for people 50 and older due to colon cancer screenings. Dr. Shekar Narayanan, colorectal surgeon with Community Health Network, is our guest for the program. Dr. Narayanan, explain who is most at risk for colon cancer.
Well, Linda, there's a variety of different patients that would be at risk. On a personal level, if you've had a history of polyps or cancer already, you are already at risk. But let's take those patients out of it. People who are higher risk per se, well, if you have a family history, specifically if a family member, a first-degree relative, was diagnosed before the age of 60. If you have a genetic disorder, some sort of unfortunate situation when your genetics through your family are creating polyps or cancers, those are high risk. Family history of polyps, that would also put you at higher risk. And then the last one would be a history of inflammatory bowel disease, people with Crohn's or ulcerative colitis. Those are basically the most common risks we see. Then there are the secondary risk factors that we also believe increase the risk of cancer. Those are diabetes, smoking, sedentary lifestyle, obesity, and then some would say alcohol. But those would probably be the major risk factors, but the biggest one being family history or personal history of polyps or cancer.
And you mentioned polyps. What are polyps?
Polyps are basically abnormal growth. So basically the lining of your colon, due to numerous factors, whether they be genetics or environment or local trauma, develops a growth. And these polyps then are usually called adenomas, are the most common. And then these adenomas can progress over time, if untreated, into, unfortunately, colon cancer.
What is the typical age in which someone would be diagnosed with colon cancer?
Well, if you take all comers, about 90% of all colon cancers are diagnosed after the age of 50, which is why the recommendations for most people are age 50 for their first colonoscopy. But there is a large subset of people who do not fit into that criteria. Family history, for example, personal history, and the other things we discussed. And the important thing is, and the way I kind of phrase it is, really a colonoscopy at age 50 is the end, or the end of when you should really be getting one. If there's another reason before family history, you have symptoms such as bleeding or any other symptoms that go along with colon cancer, you should be checked at a sooner age than 50.
Well, let's get into a little bit more about the signs and symptoms of colon cancer. You mentioned bleeding is one. What are some other things that people can look for, that common and not so common symptoms?
I think that most common would be bleeding. And then the less common, but still fairly common in the grand spectrum of colon cancer, would be an alteration or a change in your bowel habits. People who were traditionally regular now would become more constipated, or all of a sudden they're having multiple loose stools during a day. That would be something to worry about. We call that an alteration of bowel habits. Unrecognized weight loss, early satiety, or just not having a good appetite. Your abdomen is getting a little bit larger. Those are kind of the more common things that can go along with colon cancer. But I would say bleeding and a change in bowel habits would be the two most, if you are symptomatic.
And how is it usually diagnosed, colon cancer? And when should a person, you say age 50 is when they should get their first exam? Any other exams that would come before that?
Yeah, so I mean, basically at a much early age, usually a primary care physician will be doing a rectal exam on you, and then sometimes they'll be taking these little cards and they can detect blood on the stool card. It's called a stool test, basically. There are some more advanced tests that have also come out that have been a little bit more sensitive than traditional, Hemoccult is what it's called. A colonoscopy is the best method of detecting colon cancer. For a normal, not high risk, it's age 50. Afro-Americans are age 45. But I always tell people, again, that's the end. If you have a family history of polyps or cancer, you go to 40, or if it's a first-degree relative, it is 10 years before they get diagnosed. So God forbid your father was diagnosed at age 42, you're age 32. So that's something that people don't really realize. Everybody thinks 50, 50, 50. 50 is the end. If there's another reason, it should be before that.
Good to know. Everyone talks about the drink mix that is taken before a colonoscopy procedure. I guess that's the procedure typically to diagnose the cancer. And it clears out the colon, which is important to be able to go in and get a good image of the colon during that procedure. So is that still a standard method to clear out the colon? And is it really all that bad in today's standards?
Yeah, that's a great question. So, I'm going to divert off just for a second. So there are other tests that you can use. There are specialized x-rays, there are specialized CAT scans, and they each have their advantage. And the biggest reason people worry about colonoscopies is the sedation. They don't want to be put to sleep, or there is always some risk with putting a scope up somebody with air. But these other tests do not have the sensitivity or specificity And if they find anything that looks abnormal, guess what? You got to go have a colonoscopy. So as long as your health is generally fairly good, most people recommend colonoscopy as a starting point. Now go back to the preps. Now, obviously preps are always the biggest point of discussion with people. I have tried almost 95% of them because I always feel like I got to know what someone's going through. And the original ones are tough. There are a lot of volume. There's usually about 4 liters. But this has all changed. And now there are low volume preps. There are even pill preps. And there are a lot of pills and they're pretty big, but some people can take a lot of pills or some people can take a lot of what we call low volume preps. They don't taste as bad. You can mix them with Gatorade. And I think it is really dramatically different than, let's say, 2000 or 1995, where all we had was the big, very salty tasting solution. That is few and far between at this time.
Getting back to polyps, because some people may have a polyp that is found during a colonoscopy, but they don't have the cancer. How much greater risk does that put you at cancer, and how is that treated?
Yeah, so most polyps can be removed through the scope. There's different varieties, whether it's through a lasso or basically biting it off, depending on the type of polyp. And they break down these adenomatous polyps into 3 different sections, some with a little higher risk of cancer and some with a lower. But usually when you have your colonoscopy and you have 1 or 2 polyps, they'll recommend a follow-up in, let's say, 5 years. If you have several or some bigger ones, they recommend 3 years. And if you have some that were removed in like what we call piecemeal, where you kind of took it apart to remove it, then they may even recommend another one in 3 months, 6 months, or a year. The goal of that is prevention of cancer. People at polyps are at higher risk. You're always going to be on a higher risk, what we call follow-up protocol, rather than the traditional 10 years. That's for someone who they don't find anything and has no family history.
Once a colon cancer is diagnosed, what is the typical course of treatment? What can a patient expect at that point?
Yeah, so the main thing is the primary treatment of colon cancer itself is going to be surgery in the most part, okay? And so it all depends on the location. And usually after the diagnosis, we'll also obtain some imaging, and the most common being a CAT scan. And we'll get that of kind of your chest and your abdomen or stomach area and the pelvic area to look for signs or symptoms that has spread somewhere else. Then the primary treatment is surgery. We'll remove that area, usually put things back together, and then we usually see our oncology colleagues. Now, that is colon cancer. People sometimes don't understand there's also rectal cancer. So rectal cancer is things that are lower, okay, kind of towards the rectal area, even getting close to the anal area where you have a bowel movement. That can sometimes be treated a little differently. The staging is a little different, where we do some testing, either an MRI or an ultrasound. And oftentimes people will need chemotherapy and radiation first, then surgery. Usually chemotherapy in colon cancer is reserved for people that unfortunately has spread somewhere else, or their lymph nodes that we removed during the original operation comes back with cancer cells. But if you don't have lymph nodes on your cancer specimen, most typically you will not get chemotherapy.
Now, does a colonoscopy also detect rectal cancer?
It does, and it's really an anatomic difference. The colon and the rectum blend together. It's just a certain level up from the anus where we say this is colon cancer or rectal cancer. It's purely anatomical. They are really one contiguous organ. So as colorectal specialists, we make a determination of the difference because it changes how we do surgery, and it changes whether they need to see another specialist to help the patient get the best outcome.
Lastly, let's go ahead and emphasize screenings for people. How often should they get screened, and what are the follow-up recommendations in general for colonoscopies?
So generally, the overall straight guidelines are if you have no risk factors and you are not Afro-American, it's age 50 and then every 10 years afterwards, provided they don't find anything. That's the traditional answer. If, however, you have a family history and a first-degree relative, you are age 40 or 10 years younger than they were diagnosed, or if you have multiple family members with ages who have polyps under the age of 60. So that's basically a good starting point. If yourself, let's say at age 38, you had rectal bleeding and your endoscopist found polyps, then that screening follow-up is going to be different. If he found 1 polyp, he may say 5 years. If he found multiple, he may see 3 years. If he found several and one is large, he may be 1 year. So that's why it's important to have good communication with the endoscopist to know, what is my follow-up? Why am I having another one in 2 years when everybody else is 10 years? Because there is some feature that he has found or she has found in your polyps that make you high risk. The reason all this is done is all polyps that are adenomatous, quote, have a potential malignant transformation, which is what we're trying to avoid, that you not get colon cancer.
Important information. Dr. Shekar Narayanan is a colorectal surgeon for Community Health Network. For more information about colon cancer and to watch an actual colonoscopy, visit ecommunity.com/cancercare. You're listening to eHealth Radio at Community Health Network.